people are reducing their overall risk profile, maintaining their weight, looking at their glycemic control, maintaining their hypertension, and so on and so forth. And therefore, there are in the 10,000 cohort, there are a sizable population who are reducing their risk profiles. I will not divulge anymore because I don't want to take the storm out of Dr. Srividya's presentation in Health of the Nation in 2 weeks, in 2 months' time. But then the fact is, when we publish these results on a prospective scale, how this AICVD or for that ProHealth is working, the numbers are staggering.
Thank you.
Hello.
At this point, I'm also going to ask, yes, Dr. Shashikant.
I just want to ask one question. When we are going for a target in control of lipids, where should be our levels as either on a LAI or AHA scores in a high risk person?
Interesting.
Cholesterol targets.
Yes.
Cholesterol targets either LAI or AHA. But LAI is a little stricter than the AHA.
Rahul, you will want to take that question?
Yeah. So, if we look at comparatively the Western population and the Indian population, and all the criteria which on the basis, the foundational basis on which the LAI became more stricter is that Indians are getting heart disease at a lower cholesterol level compared to the Western counterparts. So all these guidelines were made more stricter, and usually I tend to follow, and there's no harm. And in fact, all the Western guidelines have actually followed those stricter guidelines after the LAI also. So if you look at the European or American guidelines, they have also come down on the target in extreme high risk or high risk group. So they say less than 55, while in the extreme high risk group in the LAI, we say go less than 30. Now they have a little, I was one of the part of the forums that they also wanted to make it a little stricter. But because of the insurance policies and all, and there are in certain countries that if the general practitioner doesn't get the LDL below a target which have been designed in the guidelines, they don't get the reimbursement, they don't get the payments. So they made it a little 55. So if you ask me practically, I would want to go for LAI and more stricter control of the LDLs in the Indian population because of the high risk nature. Being Indian itself, the South Asian population itself puts us into a high risk category. And based on all these data that at lower cholesterol, at lower age, we are getting it. So I think earlier, longer and stricter control, lower and longer duration, you keep the LDL like that. I think it is going to be good for our patients.
But the compliance is an issue because with those high doses, the people get jittery. But they do get some sort of side effect, not exactly the muscle weakness or something, but they do get jittery about continuing with medicine and a psychological feeling that I am at the age of 30 and you are giving me 40 milligram of atorvastatin because my LDL has not reached to the level that you want. With a bag of
that's where the role of art comes.
Yes.
Yes, true. So there is this tug of war is always going to be there, whether we are going to increase the HDL or we are going to lower the LDL. We all know that individually lower HDL does not have any big long-term predictive value vis-a-vis elevated LDL level. But what Rahul said in the beginning was very correct. That we have had people with coronary artery disease whom the LDL was absolutely normal or less than 100. I mean, there is still a very big population in India where the lipid levels are normal. We actually cannot predict their coronary event on the basis of that. So there is much more to cardiovascular event than just lipid profile. So the risk stratification at this stage really, really matters where we talk about family history, genetics, diabetes control. What we are seeing in women post-COVID is that, which is something which again you've not heard of, is that women as young as in their early 50s are developing triple vessel disease and they are requiring bypass, wherein it is not even considered in their risk factor at all, because we are saying women only above the age of 60 are going to develop coronary. So it is going to be a very high task or high ask for Dr. Sujoy to try to figure out a preventive health, I mean, for the, again, how to say, AICVD 2.0 to, include menopause, perimenopausal women. Diabetes in women is a totally different population, young adults, and the, uh, the data which we are getting from pediatric age group, that is adolescent age group, is again very, very staggering. So I think we are not really very, very proud of being Indian, capital of the world, being for diabetes and for coronary artery disease. Yes, Dr. Shivkumar, you can unmute yourself and please ask whatever you want to.
Yeah. I'm so happy that you finally nailed the question very rightly. This is what is the challenge. Actually, you can go back and say your first question is, why did we start this score, or what was the reason? So this was the primary reason, because I've been here an aggressive interventionist, and in my Apollo Secunderabad, it's almost like an assembly line. Every day we do almost 7-8 angioplasties and so on and so forth. And for years and years and years and years, I faced this question very often that, the person is absolutely teetotaler. He has no risk factors. He comes with an MI. To tell the attenders and the relatives and the patient is a Herculean task, because he never accepts what has happened, why, and we don't know what is the reason. So that is the reason I firmly believe AI is the answer. The problem is in our mindset. We think only these 5, 6, 7 risk factors are responsible for coronary disease, nothing beyond it. But the fact is, there are many reasons which are beyond these 5, 6 risk factors. And that is the reason the model 2.0 is going to have a stress factor, stress assessment completely. Yes. Also increase to objectively see what is the physical activity and other things, and also, of course, the premenopausal, menopausal, and the hormonal supplements and other things. And there are many more, which I'll tell you once the model comes. So coming back to your point is, AI, the beauty is AI is that only because it can correlate between the two risk factors, the non-parametric correlations. That's the most important point. All the regression analysis, they do only y-end axis and they only see a linear correlationship. When you go non-linear correlationship, the hidden, that's how the machine learning and the deep learning does it, because it can read the hidden patterns between the risk factors. These hidden patterns cannot be extrapolated, cannot be brought out by the usual regressive analysis, whatever the logistic regression analysis, we use it in statistics. So that's the key point. If somebody can understand that, the AI AUCs, although we have done the same risk factors which were there in Curie scan, the Framingham and other things, but our AUCs were much better than the Framingham's AUC. Why? One can ask, logically, you can think, you have the same risk factors, but why is the outcome is different? That's the reason its outcome is different, because the machine learning does it differently. It doesn't require a hypothesis to come out with an outcome. It reads inter between the whatever the patterns are there, and then it comes a supervised learning. Of course, I don't want to get into the AI one, but that's that's how the supervised and unsupervised learning outcomes come out. So I'm happy at least you brought the question at the end, and thank you.
Yes, thank you. Yes, Dr. Sujoy, to wrap it up.
No, Dr. Srividya, you touched a very sensitive question when it comes to, where we're doing. And I think, this is what we are learning. And first of all, I must thank and congratulate all the doctors who are participating on this. We are beginning to get, in fact, we have a very, very robust quality of data to build models this today, right? That is definitely coming in, and thank you for doing this. Sir talked about the technologies that we had 5 years back when we were building AICVD, deep learning, and others that were coming into the scene, and we were doing on that. Today, we have the powerful tool of, the generative AI, or the perspectives that we are looking at natural language processing, where we are able to now parse about close to billion data points. In one of the research that we are doing on early warning sign, we just have 6 vitals, but 6 vitals gave us 7.5 billion points over a short period of time to actually work on and get the inference out of it. And similarly, we're seeing this in ECGs, we are seeing this in other databases to actually come together and build this. Now we are, of course, taking other models of imaging, like what Vijay was referring, and seeing, how can we then go about and extrapolate certain findings in that way. So there is a lot of future. There is a lot of things that are going to come into this pipeline. But I would say that the model is now robust to trust. The model is now robust to have explainable format in which you can then go about using it, not only for your clinical reference, but also to guide your patients in that way. And the whole purpose for us is not to push this, but to say how the trust moves from the algorithm to you, so that it moves from you to your patients in the way that it takes form. I'll stop there.
Thank you very much. And if there is any other question, please write to us. We will forward it to the panelists, and you will have your answers. And we are always available here at ProHealth to pick up any thread from anywhere and help you out. And really, thank you so much, Dr. Sujoy, Dr. Shiv Kumar, Dr. Rahul, and Vijay Kumar sir, and Dr. Shashikant, and all the physicians, because I know this is a very, very busy afternoon time for all clinicians. And I really appreciate every first Wednesday regularly people who are joining us for these talks, and looking forward to your suggestions about what other topics we can do for these discussions and the ProHealth talk. And so signing off from the ProHealth team here at Chennai, thank you very much. And a very, very happy New Year to you all. Thank you very much.
Thank you.
Bye.
Thank you. Bye-bye.